So let's end with a final patient. We'll say a 68-year-old male has recurrent undifferentiated pleomorphic sarcoma, really metastatic disease, widespread metastasis, asymptomatic. And so how do you approach this patient?
I think since the patient is asymptomatic, we can use drugs that have less toxicity. You could do the Adriolera again, but I think pazopanib would be a good option as well. If
in the frontline setting?
Well, no, I'm
We've been
just
treated with
saying I'm
pazopanib.
going through.
Yeah, yeah.
I'm going through adriamycin, olaratumab, and then you can kind of go on to.
Yeah.
But frontline setting, I would say Adriolera if the patient can tolerate. If not, again, the Ganjoo every 2-week regimen, gemcitabine, docetaxel, has been very successful in undifferentiated pleomorphic sarcomas.
Yeah.
So.
Ifosfamide, AIM.
So
Not in the 68.
yeah, so in a 68-year-old, again, if they're asymptomatic, I don't see a need to get a significant response, assuming they have a significant burden of disease. So I agree, doxorubicin in combination with olaratumab in the front line. If their patient were a little bit older, if I had concerns about standard doxorubicin or the combination with olaratumab, I will actually consider liposomal doxorubicin as a single agent.
So can you just, we haven't mentioned liposomal doxorubicin before. Can you just give some of your thoughts?
Yeah, so there's been at least one phase 2 study of about 100 patients. I think it was performed in the UK, looking at doxorubicin standard dose compared to a liposomal variant at 40 milligrams per meter squared monthly. And at least in that randomized phase 2, the efficacy was similar between the two. So for me, I think it's a very reasonable option, particularly if I have concerns about a patient's ability to tolerate standard dose doxorubicin.
And any other thoughts with UPS?
Well, I mean, so I think depending on how the behavior of the UPS is, if this is incredibly aggressive, and I think immunotherapy is going to play a big part, whether it be in a clinical trial or off-label use, frankly. I think that I've had personal experience as well as experience on trials that these are the patients that can respond really, really dramatically with this. And so it's hard to justify that if the tumors are doubling every 2 weeks, right? And so you need to have time to respond, but I've seen some really dramatic long-term responses in the UPS protocol for immunotherapies as well, including some antibody-drug conjugates.
Again, I just want to temper the enthusiasm for immunotherapy. I completely agree. If there's a histology that's going to respond to immunotherapy, UPS is probably going to be it. But I really would caution the viewers about jumping to immunotherapy in the front line.
Oh, no, I don't think the front line, but I think at some point this patient, if they can wait that long to get efficacy of the immunotherapy, should get it.
I think I want to change my answer. I think one of the things that you said here was asymptomatic, but it depends on how much disease they have. I mean, they could be asymptomatic 1 minute, and then 2 hours later, of millimeter growth, they could be having hydronephrosis and all those kind of things. So I think I would still go with Adriolaratumab as to treat this patient, even though it's asymptomatic. That was my correction.
Sounds great.
So you didn't say immunotherapy.
Not immunotherapy.
Yeah, I agree with Kristen.
You guys are
Everybody
agreeing.
else.
This is
We're
good.
agreeing. Yeah,
I would
that's
treat
great.
with doxorubicin-based frontline regimen, doxolera, or if I have not examined this patient. If he could tolerate a doxorubicin doublet with Alera, that would be one consideration, particularly on a clinical trial, because it's not standard. And then I would again still have the goal of treating as aggressively as in a shared decision-making way he wants to be treated, realizing that even with pleomorphic sarcoma, there is a small cure fraction.
Yeah, that's right.
And I always preface it with the patient because I don't want to be unrealistic. I don't want to get anybody's hopes up, but from my approach, it's as the optimist, and and we discuss that.
Yeah.
And this is the patient as well that you would want to get NGS.
Agree.
Because
Great idea.
these are the patients where they have actually these translocations that may be targetable.
Yeah.
If you win the lottery and you have an NTRK fusion, there are excellent trials and excellent drugs available for that.
We know so little about these unclassified and undifferentiated pleomorphic sarcomas. What other area of oncology doesn't have a classification for their tumor?